So our objectives today, first, we are going to go over the effects of opioid use disorder. A lot of this you probably already know, but since I don't know where everybody's coming from, I'm going to just start everyone on the same foundation and we'll build on that together. Then we're going to discuss the impact in our world today of opioid use disorders and specifically with pregnant women. Then we're going to move into how buprenorphine can help and how it works. And then lastly, we're going to discuss the effects of buprenorphine on mom, on baby, and long-term. Opioid use disorder. So I want to first compare this to diabetes. Opioid use disorder as a chronic illness is what we're looking at. For a long time, there were two schools of thought, either, and this goes with type 2 diabetes too, is this a chronic disease or a bad choice, right? And we say, why can't it be both? As far as diabetes goes, what extent is the illness attributable to learned behavior, such as eating unhealthy foods, things like that, or to pathology, disrupted endocrine function? When I have a newly diagnosed type 2 diabetic coming into my clinic, there's a lot of things I'm going to evaluate first. I'm going to look into the physical aspects, right, of type 2 diabetes. I'm going to think, how much exercise is this person getting? Can they get exercise? Maybe they have chronic knee pain, right? Things like that. So there's a physical component. There's a genetic component. We see lots of diabetes running in the family. There's an environmental component. What kind of foods do they have access to? Maybe they live in a rural area and don't have access to a lot of great foods. With some mental aspect here, we've all, I'm sure, been guilty of eating some ice cream when we're feeling depressed and feeling down and things like that, and using food at times as a coping mechanism. And what's the social determinant here? What kind of things do all their friends do? Are they all going out every night of the week, eating fast food and so forth? So when someone comes in with type 2 diabetes, I'm going to address all these. I'm going to get them set up with a nutritionist, talk about exercise, and I'm also going to prescribe medication. Same thing goes with opioid use disorder. So let's walk through these again together with opioid use disorder. It's a huge physical component, right? If someone is going through opioid withdrawals, they're going to feel so sick. I don't know if you yourself have ever experienced opioid withdrawals or witnessed it, but it is miserable. Nausea, vomiting, diarrhea, chills, sweating, insomnia, headache. It's awful. So a huge physical component. There's a genetic component. We see a lot of times addiction runs in the family, and then you can go back through learned behavior versus genetics, but still there does seem to be some familial component here. Huge environmental component. For my patients that might be sleeping outside, what is everyone in their environment doing? Is it all around them? Huge mental component, right? Lots of times our patients are self-medicating with opioids to deal with depression and anxiety and bipolar disorder and schizophrenia and things like that. A huge social component. What is everyone in their fringe group doing? And so when someone comes to me with opioid use disorder, I'm going to approach it much the same way I would any other chronic illness. We're going to try to address the mental health component, give them good mental health care, talk about their environment. If they're experiencing homelessness, get them housed, talk about their social circle. But then we also need effective medication to help with those physical withdrawals and things like that. I don't know if any of you have ever tried to get off of a substance. I think we all probably are addicted to some sort of substance. I know for me personally, it would be coffee. I don't even drink that much coffee. I will have, 1 cup in the morning and 1 cup in the afternoon. However, when I was pregnant, I tried to cut out that 1 cup in the afternoon. And oh my goodness, it was so hard. I can remember getting headaches for a while, feeling a little nauseous, being so tired on top of pregnancy. And even those first few days, I can remember even dreaming about it at night, knowing that I was going to get some the next morning. And that's just coffee. I can't imagine how difficult it would be for someone that might have been, using pain pills or heroin multiple times a day for the last 10 to 15 years, right? And then find out that they're pregnant, and it's overwhelming enough being pregnant. And then to think about all that can come with trying to get off an opioid. I know for me, at least, I've had 2 children. That's an overwhelming feeling in and of itself. Even when I was planning for it and felt quote unquote prepared for it, I was overwhelmed. I can't imagine how overwhelming it would be to be maybe experiencing homelessness or not feeling like you're stable in your relationship and not having a good source of income and using opioids and knowing about withdrawals and all of that. That would be incredibly overwhelming. And so we really need to help people break this cycle. Most of my patients, when they come to me, tell me, they're using just not to feel sick anymore, that they're not using, whatever we want to call it, euphoria, to get the euphoria or the high or whatever anymore. They just don't want to feel sick. They feel like they got on this roller coaster and got strapped in. And at the beginning, it might have been a lot of fun. But then after a while, they are sick and just want to get off and can't. I have patients that tell me, they'll stop using for a couple of days and they go into terrible withdrawals and they have to show up for work the next day and they don't know what to do. So they use just a little, just so that they don't feel sick and can get to work that day. And then they'll try not using for a few days and it happens again. And it's a cycle and people just want to get off. Often our patients at first have difficulty coping. So let's imagine another patient, a patient that maybe started using when they were 15 years old, a common thing I hear. And now they're 29, just found out they're pregnant, and they've been using multiple times a day for the last 15 years. And think back on yourself during those formative years of teenagers and early 20s. And every time, you have a bad day or get anxious, overwhelmed, you're learning how to cope with that, right? Sometimes we do it better than others during those years, but you're learning. Those are formative years to learn how to deal with the stressors of life. But what if instead, every time those things happened, you were using a substance to numb those emotions and that pain, right? And you haven't dealt with any of the trauma and pain and depression and anxiety. Now, suddenly you're pregnant and that's overwhelming, and you come in and we are taking away the numbing substance, right? Now, all of a sudden, all these emotions, all this depression, all of these memories you might have suppressed and trauma it's like a floodgate, like a dam just opening. That's overwhelming. And unless we have things wrapped around these patients to really help them, they're at a high rate of returning to use because they simply don't know how to handle that. We also, as I mentioned on the previous slide, their social network and support might have to change. That's asking a lot of people, right? That might be asking them to move if everyone in their household's using, to change their entire friend group, friends that they might really care about. That is a lot to ask of someone. And so we need to truly wrap around these patients and provide a lot of support. These next few slides are going to be rather bleak, and they are all saying essentially the same thing, and that it is getting bad, current trends in opioid use disorder. I actually, about 20 minutes before this started, got a notification on my phone from ASAM, and they said that they estimate overdoses from opioids have increased 30% during the pandemic. And we'll get more to that in a second. But in Texas specifically, it's increasing. You can see these blue bars indicate all opioids, so increasing right there. Here's some unfortunate things that are really hard to combat. So you can see prescription opioids. We have started to decrease those, which is good. There was a lot of overprescribing of opioids for a while. There is certainly a time and a place for prescribing opioids. You break your arm, you got a kidney stone, right? There's a time and a place for opioids. And so that is needed. But for a long time, we were overprescribing those. And then we have started to try to reel back on some of that. Unfortunately, some patients that were dependent on opioids physically were cut off from their supply quickly. They went into quick withdrawal, they were maybe experiencing pain. And so unfortunately, many turned to heroin during that time. And you can see as prescribed opioids decrease, heroin has increased. And we see that trend. And so something we need to be aware of if we are prescribers and taking someone off of opioids, to taper them in an appropriate manner and talk about other forms of pain control. Current trends related specifically to the pandemic. So this is a timely and very sad slide. I don't know if this is covering it up on the bottom at all, but let me try to show this a little bit. So the black line is going to show mobility. And so this is percent change 0. So the way this was monitored is a little creepy, but interesting nonetheless. They were able to get data from our cell phones. And most of the time our cell phones are going about to work, to the grocery store, to the park, to the gym. And that is this movement here. Okay. So this was our baseline movement about the country. Last March when COVID hit, and we had the shutdowns, everyone stopped moving. So it dropped down. Everyone was staying home. Cell phones weren't going anywhere. It has started to level off again. Here's August. Okay. It's still not back to baseline. So essentially everyone's staying home. You can see what happened during that same time. Overdose cardiac arrest skyrocketed. Patients suddenly were feeling isolated, lonely, stressed, losing their jobs. Their sobriety networks were decreased. So, I mean, if you think back to during that time, AA often was canceled because no large group gatherings. Some of them still had online stuff, but a lot of patients might not have had internet access. So AA was stopped, but liquor stores stayed open, and many other examples of things during that time. And so overdoses have increased drastically during COVID, and we are seeing the fallout right now still from that. I have had more patients overdose and pass in the last couple of months than I had my entire career. Continuing on, it is believed that about 70% of all drug overdoses in the United States are due to opioids specifically. So that's including methamphetamines, cocaine, alcohol, benzos, right? Of all overdoses, 70% are due to opioids. In 2019, there were about 50,000 deaths in the US from opioids. If you compare that, I just wanted to see what it was like. There was 36,000 car accident fatalities that same year. So opioid overdose deaths outpaced car accidents in 2019. That was before the pandemic. I can only imagine what it is now. This graph is showing types of opioids. As you can see, as we've decreased our prescribing of opioids, good, right? Heroin is also decreasing, but it's decreasing because fentanyl has become more readily accessible and it is much more deadly. How does this compare to pregnancy? It's the same. It's estimated that it's quadrupled from 1999 to 2014. And of course, neonatal abstinence syndrome has followed suit. So nothing surprising there. Another really interesting stat released by the CDC a couple of years ago is, for about the last 100 years, the average life expectancy in the United States has continued to increase, right? Medicine has gotten better. Vaccinations have come out. So our life expectancy has increased until the last couple of years. There have been so many opioid overdose deaths and suicides in the last few years. The United States average life expectancy has actually started to decrease from those things alone. That is nuts. How does it affect moms? So besides opioid overdoses, there's other ways it affects. If you're injecting, it puts them at a high risk of HIV, hepatitis C, cirrhosis, motor vehicle accidents, suicide, infections, right? Cellulitis, endocarditis of the heart, increases miscarriages. For moms that do carry to term, there's more likely custody loss, foster care, depression, longer hospital stays. So many sequelae. This slide could go on. And how does it affect baby? So a few unfortunate things we see are, take that mom that has maybe been using and finds out she's pregnant. And oh man, she really wants this pregnancy. And she knows that she shouldn't be using, so she stops using on her own and goes into withdrawal. When mom goes into withdrawal, the baby goes into withdrawal. And withdrawal in a baby can cause sudden miscarriage. And so it's sad because sudden cessation can lead to sudden miscarriage. It increases their rates. And so we actually don't encourage moms to stop using suddenly, but to come see us first so we can help them do this safely. There's a lot of fear for moms who are using to come into the clinic because they're worried the first time they come in that we're immediately going to report them. And so they're scared to come in, and we want to reduce that barrier. We want to let them know it's a safe place to come in so they can get treatment. The wonderful thing about pregnancy is it is 9 months. And so that gives us 9 months to wrap around this mom and to really get her on a good footing so that when baby comes, she's ready. Other effects on baby are poor birth weight, preterm birth, Of course, neonatal abstinence syndrome, that's why we're here, right? Poor feeding, some possible birth defects. There's still more research needed on that. Abrupto placenta, intrauterine passage of meconium, which can cause breathing difficulties in the baby, and maternal death. So those were all really sad things, but there is hope, guys. There is hope. So this is going to be a more optimistic portion of the presentation. So there are programs out there. Lots of times they're referred to as MAT programs or MAT programs. That wording, just so it's all in your brains, might be changing soon. There's also different thoughts as to what MAT stands for. Medications for addiction treatment is sometimes used, medication assisted therapy, whatever we want to call this. It's programs to help with opioid use disorder. So you can see that MAT reduces heroin overdose deaths. Great news, right? So this green dotted line is the introduction of buprenorphine. It started being more widely prescribed in the early 2000s. And as it was prescribed, what happened to overdose deaths? Decreased, which is great news that we actually have something to fight this. SAMHSA and ACOG both recommend treatment with methadone or buprenorphine for pregnant women in conjunction with those other behavioral therapies and medical services. Some studies indicate that MAT programs reduce overdose deaths by up to 40%, which is amazing. So buprenorphine, what is it? There's a lot of different names out there for it. So I just wanted to flash this on the screen so we all know what we're talking about here. So Suboxone or Subutex are the name brands for this. Zubsolv is this weird one out there. You're not going to see it that often, but you might see it. Zubsolv comes into big hand. It's very handy if the patient doesn't have insurance or is awaiting insurance because they have a 2-week coupon on their website for free. And so often if a patient comes in and doesn't have insurance in place yet, we'll do Zubsolv for 2 weeks and then transition them to Bupe. Bupes or subs are what patients call them, or buprenorphine and naloxone. So what is buprenorphine? Buprenorphine is a partial mu agonist. So I'm not going to get into the pharmacodynamics too much here, but this stuff is important for our pregnant women. And so we'll pretend like this is our receptor and it's a mu receptor. And that's what all opioids bind. Heroin, pain pills, methadone, bupe, they all bind mu receptors. And that's going to affect pain, right? Euphoria, things like that. Buprenorphine is unique in that it's a partial agonist. All of those other ones I mentioned are full agonists. They fully bind that receptor. Buprenorphine is a partial agonist, so it's only partially binding. So what's that mean in real life? Since it's only partially binding, it's not going to produce that euphoria or high that the other ones do typically. It is going to help with cravings and withdrawal symptoms, which is great, right? It's going to help people feel good and not feel sick anymore so they can start to address their mental health and their social needs. The other unique thing about buprenorphine is even though it's only a partial agonist, it binds receptors stronger than the other opioids. So what's that mean for us? That means if we have a patient that is taking their buprenorphine regularly as they are supposed to, and then say they have a moment of weakness, say their dealer drops by, they've had a bad day, something happens, and they use heroin on top of it. It is going to block the effects of that heroin and they won't feel any. I've had numerous patients tell me this is true. Usually they're new to the program, but I've had quite a few patients come back and say, Dr. Emily, I didn't believe you. And, I tried. I used a little heroin on top of it. And it was the biggest waste of money. I didn't feel a thing. That is great news. So it's going to prevent overdose because the heroin can't find the receptors. It's going to give them about 24 hours. That's how long it stays in the system to have some clarity and think their decisions. Conversely, buprenorphine can precipitate withdrawal. So what I mean by that is let's reverse the scenario. So if someone comes into our clinic and has recently used heroin, and isn't maybe honest with us about how long it's been since their last use, and then they take buprenorphine too early, what will happen is that buprenorphine will knock all the heroin off the receptors and they'll go into sudden precipitated withdrawal until the buprenorphine can take hold and they feel really sick. We don't want that to happen. We absolutely don't want that to happen in a mom because that can induce a miscarriage. So what we need is we need about 12 to 16 hours between last use of opioid before they start their buprenorphine. What are the side effects of buprenorphine? Great news is there are very few. Constipation is one of the main ones because it's fighting those opioid receptors, right? So just like any other opioid, sometimes there's fatigue, especially early on while we're adjusting the dose. Sometimes a little headache, but that's not even that common. The most common feedback I get from patients is they feel they'll come in and they'll say, I don't feel high. I don't feel sick. I don't feel anything. I just feel like my normal self. And I'm like, that is great. That is what we want. We want you to feel nothing. We want you to feel clear-headed. We want you to not feel withdrawal symptoms, not feel cravings, so that you can start to concentrate on all the other aspects of your opioid use disorder. So let's compare buprenorphine and methadone just a little bit. Because methadone, as mentioned, it's been on the market since about the 70s, so it's much more well known, but there are some key differences. So going back to our previous talk about agonists and things, buprenorphine is a partial agonist. Methadone, on the other hand, is a full agonist. Buprenorphine, since it binds more strongly, you cannot mix it with those other opioids. Methadone, on the other hand, you can take with other opioids, and there can be a synergistic effect. Buprenorphine has a fairly short half-life. It's going to get out of their system in about 24 hours. So that is helpful if we need to rapidly decrease someone off of it. Methadone, on the other hand, has a longer half-life. It can take me weeks to taper people off of methadone. Typically, buprenorphine is not going to produce a high. It's really difficult to misuse buprenorphine, and we'll talk more about that in a second. Methadone, unfortunately, at certain doses, it can produce a high or euphoria, and it is easier to misuse. Buprenorphine also has fewer medication interactions, and methadone can have a few more. Going back to the receptor stuff, so here's just a picture. We'll cover this quickly. Methadone full binding, buprenorphine partially binding. Naltrexone or naloxone, that's the same medication, just different route, is an antagonist. So it is completely blocking that receptor. Now, as mentioned on a previous slide, buprenorphine is combined with naloxone. So if you were all wondering, wait a minute, if it's combined, isn't naloxone blocking the effects of buprenorphine? You would be right. So this doesn't make sense. Well, some scientists that are brilliant out there figured out a way to make it so the naloxone is not absorbed, it's not activated, as long as the buprenorphine is taken correctly. And so buprenorphine is absorbed sublingually under the tongue or in the cheek. As long as it is done that way, no naloxone is activated. However, if a patient were wanting to maybe misuse their buprenorphine and crush it and snort it, or crush it and inject it, that is when the naloxone becomes activated and it blocks the effects. That's why it's so difficult to misuse buprenorphine. So how can buprenorphine help? As going back to my roller coaster example earlier, this helps people get off that roller coaster of feeling sick all the time. It helps stabilize mom, helps prevent miscarriage. It helps stop that cycle of withdrawal so that mom can have a clear head and start to get all the other aspects of life in order related to her opioid use. It is safe to use in pregnancy, and it reduces neonatal abstinence syndrome and hospital stays for mom and baby, which is huge. It helps mom with postpartum pain since it is still binding those same receptors, which can prevent her returning to other opioids. We've seen that, unfortunately, a few times in moms without buprenorphine, is they might have some postpartum pain and be prescribed some opioids. And unfortunately, then they return to use because they're postpartum and stressed and tired and overwhelmed, and suddenly they have access to opioids again. So it's helpful to help prevent that because postpartum, they'll have the bupe still going on. It's safer for baby than suddenly stopping opioids altogether. It also helps moms engage in these types of programs and get more prenatal care and connection to services. And it also reduces the risk for mom for all those other things we talked about for HIV and hepatitis and so on. So how does it affect pain during delivery? It can help. It can be adjusted during delivery to help pain management, thus reducing the need for any other opioids. If surgery is needed, buprenorphine can be continued during surgery. I have lots of patients, pregnant and not pregnant, that undergo surgery, right? And we do buprenorphine during surgery. We taper it accordingly. It can also be used with an epidural. And so easy to just maintain this throughout the whole labor and delivery process so that there's no lapse in care when they get out. Buprenorphine and breastfeeding. So it is encouraged in breastfeeding. Almost every resources I found that it should be encouraged. It has been well studied in the breast milk of moms on buprenorphine and in the urine of infants that are breastfeeding. And it has very poor bioavailability, so it's really not being transferred that much. It's very, very small amounts. And there is some thought that maybe those very small amounts that are being transferred might help the baby with neonatal abstinence syndrome because they're still getting a very, very small amount. Multiple studies I read indicate that babies that are breastfed that have neonatal abstinence syndrome spend less time in the hospital. I saw differing data on that. Some studies said average of 4 days less in the hospital, others said up to a 7-day, but all were less. So encourage breastfeeding. One unfortunate thing we see is a lot of confusion about breastfeeding on buprenorphine. I think that it's just due to just not knowing the new data. And so I think some very well-meaning social workers and lactation consultants and nurses that have the best interests at heart for these babies and moms see that a mom's taking this medication in nursing, and they encourage mom to not take the medication because they think that it's not safe in the baby. And we've had this happen a few times where a mom that has done so well for the last 9 months and not used any opioids and stayed on their bupe is in the hospital and breastfeeding, and she's exhausted and stressed and hormonal, and someone comes in and tells her, oh, you shouldn't take that bupe. It's bad for your baby since you're breastfeeding. And she stops. And unfortunately, we've had a couple of moms where that's happened. And then once they've been discharged, they've returned to care or returned to use. And then at times, they've lost custody, which is so sad if they could have just continued. And so we need to be better about educating on the safeness of this in breastfeeding. So outcomes for mothers on buprenorphine compared to those without. So let's take another example of something similar I've seen in the clinic. So let's say we have a young woman, 21 years old, and she's got a full basketball scholarship at college, and she tears her ACL, has to have surgery, loses her scholarship. And after surgery, she's prescribed some pain pills, as she should be, right? She has a lot of pain. Fortunately, she's really depressed because she lost her scholarship. Her grades are suffering. She also has lost her identity. She was the basketball star, and all of a sudden she's not anymore. And so she doesn't quite know how to deal with that. And those pain pills that are really helping her knee pain, and they also help relax her a little bit and help her sleep better. And she's just not worrying so much about everything else going on in her life right now. The next thing she knows, she's taking a little bit more than she was prescribed. She's running out early, and her prescriber stops prescribing the opioid. Now she starts finding it from other people and buying it off the street. She's got a problem. She's super ashamed of this problem, right? She don't want to tell her parents about this or anyone else. She didn't know how this even happened. It just happened. And this goes on for a few years. And then she finds out she's pregnant. She knows she shouldn't be on the opioids. She's scared to tell anyone. She's crazy scared to come in and get any help because she doesn't want us to call CPS. And so she doesn't. And so then throughout her pregnancy, she lacks prenatal care. She lacks some mental health support. She's more likely to lose custody of the child later on, depending on what happens at labor and delivery and so on. We've had moms that then do lose custody, and that often increases their depression because that's was their hope and what they were really living for. And then when they lose that, they don't know how to cope with that, and they return to use and overdose and things like that. And these are all stories that we've experienced. Flip side, we've had patients that do come in and get on the meds, and it improves their adherence to prenatal care and to treatment programs. We're trying to do better about it in our clinic, but we're housed in the same building as an OB group. And so we are trying to make our OB visits and our MAT visits on the same day. So they see their OB, they see us, they get their medicine all in the same building. We are trying to loop in the OB case managers with the MAT case managers and really marry all of this care together. It's going to reduce their risk of OB complications. Also, 30 to 40% of women in programs like this do screen positive for depression, which makes sense. And these programs can help. We have 9 months to really help wrap around them and get them on a good path. And it's also going to increase their chances to continue in sobriety long term. So what are some of the long-term effects of buprenorphine on kids? So as far as congenital malformations, there has really been found no difference between the general population and the buprenorphine population. So that's been pretty well established. Now, there is a possible increased behavior in cognitive issues. But that's really difficult for us to determine cause versus correlation, and we need more evidence. So the reason this is difficult is some of our little ones that maybe were on bupe when they were in utero, that maybe have ADHD later on or some learning disabilities. It's really hard for us to determine, was that due to the buprenorphine that their mom took? Or was that due to maybe some early exposure to methamphetamines and heroin and alcohol and other things early on in their pregnancy before mom knew she was pregnant? We don't know. And so we really need to have better understanding. So we approach this from a risk reduction standpoint. We do know that being on buprenorphine reduces the risks of Hep C and HIV. We also know being on buprenorphine reduces the risks of a lot of other things as well. It reduces the risks of mom using alcohol, methamphetamines, and opioids, those things that we know cause cognitive and behavior issues. And so we consider it risk reduction. These are all things we talk about the moms with at their visit and we go over with them. And we try to use the lowest dose that is needed for mom to negate any possible effects. I think these are valid concerns. I know for me, when I was pregnant, I was scared to even take a Tylenol, even though I was told it was safe. And so I think moms are wary of taking anything. And I think we have to be very sensitive to that and take into account all of the big picture. Buprenorphine and methadone is not needed in every mom that's struggling with opioid use disorder. Depends on how much they're using and how often they're using and how intense their withdrawal symptoms are and what their social network is. Maybe they live in a loving home and have a lot of support from their family and don't have all those other confounding issues going on. And so this might not be for them. So having a good conversation with them about what risks are and what long-term effects could be. How do we do buprenorphine differently in pregnancy? So this picture captured a little bit of how I felt when I was pregnant. I was quite miserable. I know everything seems to change when you are pregnant. And so buprenorphine is the same. We often need more frequent dose adjustments. Patients that aren't pregnant, we can usually kind of get to a stable dose and just stay there and coast. Pregnant women, though, due to fluid shifts, due to fat accumulation changes, due to metabolism changes, we have to go up and down on their dose more frequently. And so at times they might be on a pretty low dose and at times they might be on a higher dose. So we monitor them very closely. Naloxone or no naloxone in the buprenorphine? That is the question. So the answer depends on who you ask. For many years, it was advised to take the naloxone portion out of the buprenorphine when someone becomes pregnant. And that was due to a theoretical risk, not any evidence to support this risk, just a theoretical risk. The theoretical risk was that possibly that naloxone could become activated when it crosses the placenta and cause withdrawal in the baby and miscarriage. Or that, if mom does misuse, initiates withdrawal and so on. So the thought was, hey, just take it out and let's be safe. However, as we know, that then makes it a little bit easier for you to misuse the buprenorphine. And so now more studies and experts are saying you can leave it in. There's been no risks that we've noted, and so just leave it in. I kind of go with the patient, the situation and what's going on, and we talk about it. So I don't think you're wrong either way based on what I am reading right now. The initiation of the medication is more closely monitored just because we do have to have mom in a little bit of withdrawal so those receptors are open, but we don't want her in so much withdrawal that miscarriage occurs. And so we monitor very closely during induction. If it's before 20 weeks in the pregnancy, we can typically do this in the clinic, in the outpatient setting. If a patient's over 20 weeks, then I'm usually going to send her to the hospital to do the initiation. There is a lot of stigma surrounding treatment. And so there's a lot we can do just to help decrease this. It comes in small little steps. And what can we do about that? So if you're a prescriber, get waivered. It's easy to get waivered. You do have to have a special license to prescribe bupe. That is really easy to get. You just go to SAMHSA's website, and it's all CME and it's all pharmacology CME. So you get lots of credits, which is really great. I believe it's 24 hours worth of pharmacology credits, which is huge. This is such fun work. I can't express how much fun this is to do. I've had multiple patients that come in are distraught or struggling, just found out they're pregnant or overwhelmed or sleeping outside. We get them on their bupe, we get them stable, they deliver this healthy, happy baby. And I get to see them for years after that. I have them bring their kids in, and I've been seeing them for a couple of years, and they're doing amazing. And so it's so fun to get to see this transformation occur and see just this direct impact in patients' lives. So I encourage, if you are a prescriber, get waivered. It is fun and easy to do. What else can you do? Encourage moms that are interested in this. Like I said, it's not always appropriate, but if they are thinking about it, get them scheduled with the prescriber to have a conversation about it. So support them in this. Also help reduce the stigma. And this is so hard, right? It's so much easier said than done, or at least for me it is. I know that I'm pretty non-confrontational, but I've had, of course, heard, in the break room, people sitting around talking. And again, I think it's well-intentioned. I don't think people are being mean or judgmental, but when people say, oh yeah, that's a bupe baby, or can you believe that mom's taking methadone, and so on. I think that they just don't understand the new data. And so gently and kindly saying, yeah, that's tough, but have y'all actually read? That's what, American Society of Obstetricians recommends now, and SAMHSA, all the leading experts right now are actually recommending buprenorphine in pregnancy. It actually helps neonatal abstinence syndrome. It decreases it in babies. It decreases hospital stays, and it helps moms long term. So, wow, isn't it amazing this mom's actually doing this and taking such great steps? So, trying to kindly interject a little bit here and there into the conversation to reduce that stigma. Also, we just need to recognize what these moms are up against. It's not as simple as, oh, they just need to stop using. It is crazy complicated. There's so much going on in pregnancy alone, but then you add all of these other things in there. That's a lot. So lots of empathy, and encourage them to breastfeed, please. It's going to reduce that neonatal abstinence syndrome. It's good for baby. It's good for mom. So my last slide is just my fun slide. And this is not to toot my clinic's own horn at all. This is just to show what rewarding work it can be. So we did a survey last year and asking how to improve our clinic. We just had free comments at the end, and patients were just so kind and generous. And this was a lot of comments that we got. And I just got a few. We had about 3 pages of these, but I'm going to read a few just to demonstrate how helpful it can be. And they all say essentially the same thing. If it was not for this program, I'd be dead. This program has changed my life. I wouldn't change anything. This program and the folks who work here are amazing. I feel like everyone genuinely cares about me and wants to help me. You guys are great. Again, the program saved my life. Again, Matt saved my life. This program's a blessing. I actually enjoy going to my doctor. I like that one, and my appointments, because everyone really cares about me and my health and what I go through. They saved me and I love them, and so on. And so, yeah, I encourage you to, if you can, get on board with this work, because it's so much fun. So now I'm going to stop sharing my screen so y'all can just see me, and I will take some questions.
Everybody, just type your question in the chat and I will go ahead and read it.
Yes, I see the contact information. Yes, I am happy to send that out to everybody. Of course.
And actually, I did get a question on my email regarding the presentation today. The copy of the PowerPoint is in your Canvas account, and we are recording this today. So if you want to rewatch it, you can in July, you can go to our catalog and we will have, this is what we're calling enduring material, where we have that posted at that time. And you do have a question. It says, I may have missed this, but how many patients are you seeing monthly?
Great question. No, you did not miss that. I did not say that. Oh man, that is a hard one to quantify. So the way our clinic works is we see patients, it's 5 days a week, 8 to 5. And we schedule up to 22 to 23 a day. Now, we do see patients early on frequently. So that's every week. And so some of those patients we're seeing very frequently. Other ones that are doing really well, it's only monthly. So we can keep track of our patient counts mostly by our DEA log. And I believe our most recent count at our hub, which I can talk more to that in a second, is about 140 active patients in our program. Total across community care, which is who I work for, we probably have around 180 or 200. So what I mean by hub is we work on what's called a hub and spoke model. And so think of a wagon wheel. The hub is where we get patients started on the medication. We get all those wraparound services in, lots of intensive management. We're seeing them weekly or every 2 weeks, lots of touch points. And they will stay with us a minimum of 90 days there, often up to a year. And then once they're doing really well and they're stable on their dose, then they get to transfer to one of our spokes. And a spoke is a primary care provider within our system that also prescribes the medication along with all of their other chronic medications, because we treat it like a chronic illness. So whoever their primary care provider is after they're stable, they'll go to them and they'll get their lisinopril and metformin and buprenorphine, and they get to go up to every 3 months out of those. Now, for our pregnant patients, they have to stay at the hub throughout their entire pregnancy. One thing, until another question comes in, one thing we have found really interesting is depending on dose of buprenorphine does not seem to impact the amount of neonatal abstinence syndrome. And so for a while we were like trying to do the lowest dose possible for mom. But we found, and the evidence is out there too, that some moms that are on really high doses of buprenorphine, which high I would consider like 24 milligrams, their babies might have no neonatal abstinence syndrome. Other moms might be on a low dose, like 4 milligrams, and their babies might have a little bit. And so it doesn't seem to be dose specific. We need to do a little more research, but we think that it might be something related to the placenta and metabolism, things like that. But we're not sure. And so really we go off mom's withdrawal symptoms because we don't want her experiencing those. We don't want her experiencing cravings to adjust dose. So the lowest dose we can achieve without withdrawal and cravings.
Okay, we have a question. So when the baby is born, how long is mom on treatment? What about the baby's care? Does mom get support to help baby? Does mom go to counseling?
So first question, how long is mom in treatment? However long she wants. And so our treatment has no end date because we are treating it like a chronic illness. Now, going back to my diabetes example, do some people start eating great and exercising and get to come off their meds? Absolutely. Same is true here. We usually recommend baseline 2 years on medication to really get a good foundation. And then we will consider doing a slow taper. There are some people that will start to taper and they do great and they come off of it, and that's that. We have other patients, we start to taper and their cravings start to come back and they start dreaming about using and having some symptoms. And that doesn't mean they failed. That just means the brain chemistry is not there. Those receptors are not ready yet. And so we just taper them back up and we leave them there. I have other patients that come off completely and are off for a couple of years. And then maybe something happens. Maybe they go through a divorce or lose a job and they're stressed and those cravings start to come back. And they might come back to our program for a few months to get on the medicine just to kind of get them through that rough patch, and then we get them off. And then again, I have other patients that are just like on 2 milligrams, super low, for the rest of their life. At that point, it might be more placebo effect. I don't know, but they feel like they are doing something active to control their substance use disorder. And I am all for it. I'm like, no, if taking 2 milligrams of bupe helps keep you off of heroin for the rest of your life, then I'm happy to prescribe it. So we really try to tailor our plans to what the mom needs. And we are always reevaluating. My phrase always in the clinic is my goal is to help them meet their goals. And so we're constantly talking about what their goals are and trying to meet them. As far as how long do they get support and counseling, as long as they're in our program. And so at the hub, that's really intensive. Once mom might feel like she doesn't need that much, need that many visits or need that much counseling and things, we'll transition to spoke. But if they ever start to, go through a rough patch, spoke transfers them back to hub for that intensiveness. And so, yeah, it's all catered to what the patient needs.
Sorry, I was on mute.
You're
What
good.
about the baby's care? Does mom get support for help with the baby?
Sure. And so in our hub, it's a big building. So we have primary care in there, we have OB, we have pediatrics, all literally like we are next to the pediatrics clinic, and then OB is two doors down the hallway. So they can go to their baby's visit and then our visit and OB and do all of it in the same building.
Next question. Do you allow moms to stay in the program if they relapse?
Absolutely. Yes. And so that has changed in recent years. But that the alternative is, so we do know that relapse can be a part of this journey, right? If we cut mom off, right, what's the alternative is she's going to go back to use, right? And so if someone returns to use or it's not getting better, then we are going to have much more frequent visits. Say I have someone that's on monthly visits and they start using again. Those cut down to weekly, sometimes twice a week. Really frequent monitoring and shorter scripts. We do a urine drug screen at every visit that's checking for buprenorphine and all of that, checking for opioids. We check for everything. Now, let's say we have someone in the program for months on end and we are not getting better. I'm not going to kick them out per se. We are going to recommend a higher level of care. And so I'm going to say, listen, this isn't working. You told me at the beginning, your goal was to get off of all of this. And my goal is to help you meet that goal. And we're not meeting that goal. So we need to reassess. And so we're going to use our case managers and social workers to help get them inpatient treatment. And we actually can prescribe buprenorphine while they're inpatient, so that when they get out, they're already on their dose. And I'll say, hey, go to 30, 60, 90 days of treatment. We'll actually do phone visits with them while they're there to check in, get them, stable, kind of readjust everything, and then they can come back in our program. And so it is rare that I will, kick someone out. We will reevaluate and reassess the treatment plan if it's not working.
All right, we have another question. So you said you talk with a patient about if they want Subutex or Suboxone. Do you have any recommendations or criteria for the patient when you would recommend Subutex? That's the first part. I'll let you answer that.
Sure. Yeah. I mean, gosh, up until recently, I only did the buprenorphine only formulation in pregnant women, just for the Subutex, because of this theoretical risk with the naloxone. I'm slowly starting to change that based on the new things that I'm reading. Yeah, we do urine drug screens. We can send off to confirm the metabolites of naloxone and all of those things. If we are doing full physicals, checking for insertion sites, things like that. If they're misusing it in any way, crushing it and snorting it, right, and there might not be as much evidence for that, they're going to be experiencing more withdrawals and things like that. And so that's going to come to light during physical exam. Now, are there things that we could miss? There certainly is. We're not infallible. But we are seeing them frequently. Their case managers, their psychiatrists, and their OB. And there are a lot of eyes. And so it would be really difficult to let something like that slide through our clinic. We are very in tune to that, but it could happen.
I think you just answered the second part. It was, do you have any processes in place to verify pregnant client is not abusing Suboxone?
Sure. And I would argue too, and this might be a little bit, I don't know, controversial to say, but I would argue, although I do not want anyone to misuse their Suboxone ever, please hear me say that, it would be better than heroin or injecting heroin or something like that. Lots of the heroin we are seeing right now is laced with fentanyl. I have had, I believe, 4 patients overdose and die in the last month due to fentanyl here in Austin, and they didn't know it was in their supply. And so, no, I never want anyone to misuse it. It would be, if we're looking at it from a risk reduction, standpoint, less risky. But no, we don't want that happening.
Next question. Does mom come to the center as needed? For instance, does she live outside the area? Do you allow takeouts?
I'm not exactly clear on this question. Takeouts, I'm thinking might be from methadone clinics, like take homes. Is that what the question is? Like, do we allow them to take them?
Did you want to elaborate? It's from a person named iPhone.
If not, I will assume that. So I'm assuming they're talking about medication you take with them, like in a methadone clinic. Often you have to come every day for your medication, but sometimes you can get take homes to 3, 4, 5 days. Buprenorphine, we do not do daily. It's, you know, every week, every couple of weeks, monthly. So they will get a full month script because it is, you know, really difficult to misuse, although people can get around it. It is much more difficult to misuse than methadone, and it's much less risky than methadone. So we do full month prescriptions. I don't do that often in pregnant women just because I'm watching them so closely. I might go 1 to 2 weeks, but yes, they get to take some out. And living outside the area. So yes, we take anyone that can get to us essentially, you know, in the Austin area. We do some outside of Travis County, but yeah, anyone in this area can come.
Any other questions? Anybody? All right. Would you like to give your final thoughts and then we'll wrap it up?
Awesome. I'm going to go ahead and share my screen, and I have my email on the bottom for all of you that were asking for it. So this is my work email. So feel free to email me with any questions and I'll get back to you as quickly as I can. Thank you guys.
Thank you so much. We truly appreciate you participating in NAS Awareness Month, and you have a great day.